We have a story we tell ourselves about the past, and it goes like this. Before modern medicine, people were dying in the dark. They were guessing. They were praying. They were rubbing leaves on wounds and hoping gods would do the rest. And then science arrived, and we finally figured out how the body works, and everything before that moment was essentially superstition dressed up as care. That story is comfortable. It makes us feel like the most medically sophisticated humans who ever lived. It is also in several important ways wrong. Not entirely wrong. Modern medicine has done things no previous civilization could dream of. Organ transplants, targeted cancer therapy, vaccines that ended plagues, surgical precision measured in millimeters. The list is real and it is staggering. But somewhere inside our confidence about all of that, and we made a quiet assumption that because we know more now, everything before us was ignorance, that the people who came before were stumbling through biology with their eyes closed, waiting to be rescued by the future. The Vikings would like a word, not the Vikings of the movies, not the horned helmet fantasy that Hollywood assembled from fear and spectacle. The actual Norse people, the Scandinavian societies of roughly 793 to 1100 AD, who built ships that crossed the Atlantic, established trade routes from Baghdad to the British Isles, developed legal systems sophisticated enough to have written codes, and, when the battle was over and the wounded were dragged back from the field, did something that should stop you cold. They saved them. Not all of them. Not always. But with a regularity that the bones do not lie about, our Viking Age people survived injuries that should have been death sentences. They survived skull fractures. They survived amputations. They survived gut wounds. They survived infections that, without any intervention, would have turned septic within days and killed a man who had walked away from an axe with his life. They didn't survive by luck. They survived because someone knew what they were doing. This is the part of Viking history that almost nobody talks about, because it doesn't fit the image. It is easier to sell the berserker than the healer. It is easier to show the raid than the recovery. But the archaeological record keeps producing evidence that refuses to be ignored. Surgical tools buried with the dead. Skeletal remains showing healed bone after procedures that required deliberate human intervention. Feed plant preparations identified in grave goods that map directly onto compounds now studied in modern pharmacology labs. The Vikings had medicine. Real medicine. Empirically tested across generations, carried into battle, administered by trained practitioners, and grounded in an understanding of the human body that their world had been refining for centuries before the first longship ever hit a foreign shore. And some of it was better than what most people in the world had access to as recently as 200 years ago. That claim deserves to be earned, and it will be. But first, understand why it matters. Not as a historical curiosity, not as a piece of trivia to win an argument, but as something directly relevant to the body you are living in right now. Because a significant portion of what Viking healers used, say the plants they packed into wounds, the fungi they prepared and carried on their bodies, the fermented foods they consumed daily, the diagnostic methods they applied in the field. Modern science has gone back and tested it, systematically, in controlled conditions, with methodology that has nothing to do with folklore or romance, and the results keep coming back the same way. It works, not all of it. Some of it was wrong, some of it was ritual masquerading as treatment, and we will be honest about that too. But enough of it works and works through mechanisms that modern biochemistry can now explain, that the question stops being, did they really know what they were doing? And starts being, how did they figure this out 1,000 years before we had the tools to understand why? That question has an answer, several of them, and they are stranger and more impressive than the myth. Here is what you are going to learn. You are going to learn about a battlefield triage method so clinically precise that it mirrors techniques modern trauma surgeons still use, developed in the Norse world in the 9th century, using nothing but herbs and logic. You are going to learn about fungi carried on human bodies over 5,000 years ago that are now being studied for antibiotic and anti-parasitic properties. You are going to learn about a single plant whose name traces back to ancient Greek myth and whose pharmacological actions, hemostatic, antimicrobial, anti-inflammatory, have been confirmed in modern clinical research. You're going to learn about healers with surgical kits buried beside them, about skull operations with surviving patients, about a daily diet that was, in effect, a systemic medicine program that no one had to prescribe because it was simply life. You are going to learn that the Vikings had practitioners, not just folk remedies, that they had a pharmacopoeia, not just a garden, that they understood the relationship between the gut and the immune system, between the mind and the body, between the environment and disease, not in the vocabulary of modern science, but in the practical, tested, consequence-refined language of people who could not afford to be wrong. And then, at the end of all of that, you are going to have to sit with a question that modern medicine does not entirely like. What else did we dismiss? Because the history of science is not a clean line from ignorance to understanding. It is a jagged, looping, sometimes embarrassing record of insights discovered, lost, rediscovered, patented, and sold back to the people who were using them a millennium before the trademark was filed. Aspirin's story begins with willow bark. Morphine's story begins with the poppy. The story of gut health, one of the fastest growing fields in modern medicine, begins with fermented food that Northern Europeans were eating every day of their lives 1,000 years ago because it kept them alive through winter. The Vikings didn't have a word for pharmacology. They had something older and in some ways more reliable. 1,000 years of watching what happened when you used something and what happened when you didn't. That is a clinical trial conducted across generations in real conditions with real stakes, and they were paying attention. So before we talk about what they knew, and we are going to go deep, there is one thing worth saying plainly at the start. The next time you assume that someone who lived before the age of antibiotics was simply waiting to die, remember this. There are skulls in Scandinavian soil with holes drilled through them, and healed bone around those holes, which means the person woke up after the operation, lived long enough for bone to grow back, and walked away. Someone did that. Someone looked at a human skull, understood that pressure needed to be released, chose the right tool, made the right cut, and kept that person alive. That someone did not have a medical degree. They had something else. And by the end of this, you will understand exactly what it was. Imagine the morning after a battle, not the battle itself, the aftermath. How the noise has stopped. The field is quiet in the particular way that fields are quiet after violence, which is to say not quiet at all, but full of a different kind of sound. Men are on the ground, some are dead. Some are not yet sure which category they belong to. And somewhere in that chaos, moving through the bodies with a purpose that has nothing to do with glory or plunder, there is a person doing something that looks, from a distance, like feeding the wounded. They are not feeding them, they are diagnosing them. What they are carrying is a preparation, a drink made from onion, garlic and herbs. And they are giving it to wounded men not because it will heal them, but because it will tell them something that nothing else in the 9th century could. They are watching, they are waiting. And then they are leaning close to wounds in the abdomen, the chest, the gut. And they are doing something that sounds almost too simple to be medicine. They are smelling. If the wound smells of onion or garlic, if the preparation has passed through a perforation in the bowel and is venting through the injury, then the diagnosis is made. The gut is breached. The contents of the intestine are entering the abdominal cavity. And in a world without surgical repair of bowel injuries, without anaesthesia capable of sustaining abdominal surgery, without antibiotics to manage the inevitable peritonitis that follows, that diagnosis means one thing. This man is dying. Do not waste resources trying to save him. Spend them on the ones who can be saved. That is triage. That is exactly what triage is. At the systematic assessment of casualties to determine who receives immediate care, who can wait, and who is beyond the help available. It is the foundational logic of battlefield medicine. It is what every emergency room in the world practices today, dressed in a different language. The Vikings were doing it in the 9th century with a cup of herbs and a functional understanding of human anatomy that their world had no business possessing. If you believe the story that says they were just raiders who got lucky, the specific preparation is referred to in Old Norse medical and saga sources, and the principle behind it is not mysticism. It is physics and biology applied with brutal pragmatic clarity. The volatile compounds in alliums, onions, garlic, leeks, are absorbed into the bloodstream and expelled through the lungs and, crucially, only through open wounds. If the gastrointestinal tract is intact, the compounds travel their normal route and dissipate. If the gut is perforated, They take a shortcut. They leak. And a trained nose, pressed close to an abdominal wound, can detect that leak. Modern surgeons assessing bowel injury still rely partly on smell. The specific odour of fecal contamination in the abdominal cavity is one of the intraoperative indicators of bowel perforation. The mechanism the Vikings were using, and the mechanism a modern trauma surgeon uses in the operating theatre, are not different in principle. They are different only in the precision of the tools and the language used to describe what is happening. Think about what that means. It means that somewhere in the Norse world, someone observed. Not guessed, not prayed, but observed. That a preparation containing alliums, when given to a man with an abdominal wound, produced a detectable smell at the wound site. That observation was tested. It was repeated. It was refined. It was passed on. And eventually it became a clinical protocol, a standard step in battlefield medicine, used consistently enough that it appears in the historical and saga record as a known practice rather than an exceptional one. That is the scientific method. It is not called that. It does not wear the costume of a laboratory. But the structure is identical. Observation, hypothesis, repeated testing, refined conclusion, standardized application. And the Vikings were running it in the bloodiest test environment imaginable. Now understand what this tells us about everything else they were doing. Because the wound drink is not an isolated curiosity. It is a window. If a culture has developed a diagnostic tool this sophisticated, one that requires anatomical knowledge, pharmacological understanding, and the clinical discipline to use a test result to make a life or death resource allocation decision, then that culture is not practicing medicine by accident. It is not stumbling into correct answers by luck. It is operating with a framework, a body of knowledge, a tradition of practice that has been built layer by layer through the kind of hard-won empirical observation that only comes from being very close to the consequences of being wrong. Wrong meant a dead warrior. Wrong meant a wasted healer's effort. Wrong meant the man who could have been saved was left while the man who could not be saved consumed everything. In an environment that was brutal and that resource constrained, competence was not a professional virtue. It was survival arithmetic. So they got competent. The wound drink also tells us something about Viking anatomy. You cannot design a diagnostic tool for bowel perforation if you do not know there is a bowel to perforate. You cannot understand that a breach in the gut is categorically different from a wound to the muscle or the bone if you do not have a working mental model of what lives inside the abdominal cavity and what happens when it is disrupted. The Norse healers did not have anatomical textbooks with illustrations. What they had was observation of the open body, in battle, in slaughter, in the preparation of animals, and the intelligence to map what they saw onto what was happening inside a living patient. That kind of knowledge is not inferior to book knowledge. In many ways it is more reliable because it comes from direct encounter with the thing itself rather than a representation of it. A Norse healer who had watched men die of gut wounds, who had seen what peritonitis does to a body over 3 days, who had watched the abdomen distend and the fever climb, and the skin turn the colour of old wax. That healer understood bowel perforation in a way that is visceral, complete, and impossible to misremember, and they built a test for it. There is another layer here that is worth sitting with, because it is the layer that tends to make modern people uncomfortable when they encounter it honestly. The wound drink is not a treatment. It is a prognostic tool. The Norse healer giving it is not trying to cure the patient. They are trying to determine quickly and accurately whether a cure is possible. And if the answer is no, if the smell rises from the wound, then the healer steps back. This requires a kind of clinical detachment that modern medicine trains into doctors over years of practice, because the human instinct is always to try, to intervene, to do something. Knowing when not to treat is one of the hardest competencies in medicine. Knowing how to make that decision clearly, in chaotic conditions with incomplete information, and then act on it. That is a sophistication that many healthcare systems still struggle with today. The Vikings had built it into their battlefield protocol. There is also the question of the preparation itself. Not just the alliums, but the herbs combined with them. The historical record is not precise enough to give us a standardised recipe, and we should be honest about that. What we know is the principle, confirmed through the saga literature and through the logical reconstruction of the practice. The specific botanical composition likely varied by region, by healer, by by what was available in the season and the geography. But the core mechanism, volatile allium compounds as a tracer for intestinal breach, is consistent. And it worked well enough to become standard. That is the test that matters. Not a clinical trial, not a peer-reviewed journal, but consistent enough use across enough cases that it embedded itself into the culture of Norse battlefield medicine as a reliable tool rather than a failed experiment. Unreliable tools get abandoned. In a world where failure costs lives, bad medicine disappears fast. The wound drink survived because it kept telling the truth. Now hold that thought and place it next to what modern trauma medicine knows about abdominal assessment. Contemporary surgeons evaluating a patient with abdominal trauma use a combination of imaging, physical examination, laboratory values, and sometimes direct visual inspection. In austere environments, military field medicine, disaster zones, low-resource settings, the reliance shifts heavily toward physical examination and clinical judgment. Smell remains a valid and used indicator. The presence of bowel contents, identifiable by odour, leaking through a penetrating wound, is noted in modern trauma surgery literature as a sign of hollow viscous injury. The Norse healer and the modern field surgeon are using the same sense to detect the same event, and one has 1,000 years of pharmacological and anatomical science backing the understanding of why it works. The other had observation, logic, and the necessity of getting it right. The diagnosis was the same. This is where the history of Viking medicine stops being a collection of interesting anecdotes and starts being something more important. A demonstration that medical competence does not require modern infrastructure to exist. It requires attention. It requires consequence. It requires a culture that takes healing seriously enough to build knowledge about it, pass that knowledge forward, and refine it through use. The Norse world had all three, and the wound drink is just the beginning. Because while the battlefield healers were triaging the dying from the living, others in the Norse world were carrying something even older, something that had been prepared and used for thousands of years before the first Viking longship was built. Something that grew on birch trees, something that modern pharmacology is only now catching up with. The antibiotic was already in the bag. It had been there for millennia. In 1991, 2 hikers in the Alps found a body. Not a recent body. Not a crime scene. A man who had been lying face down in a glacier on the border between Austria and Italy for approximately 5,300 years, preserved so completely by the cold that when researchers eventually got close enough to examine him properly, they could see his last meal in his stomach, the state of his joints, the parasites in his gut, the tattoos on his skin, and the exact contents of what he was carrying when he died. His name, given to him by the researchers who studied him, is Ötzi, and among everything he was carrying, his copper axe, his bow, his arrows, his fire-starting kit, he had fungi, specifically prepared, deliberately carried, intentionally included in his kit, the way a modern person includes a first aid kit in a hiking pack, not gathered by accident, not picked up opportunistically on the way, prepared, strung on leather cords, ready for use. One of those fungi was birch polypore, Piptoporus betulinus, a bracket fungus that grows on birch trees across the northern hemisphere. Unremarkable to look at, pale and shelf-like, the kind of thing most people walk past in a forest without a second glance. Ötzi was not walking past it. Ötzi was carrying it on his body as a deliberate medical tool in a world that would not develop the germ theory of disease for another 5,000 years. That detail deserves a moment. 5,000 years before Alexander Fleming noticed that a mould was killing the bacteria in his petri dish, a man walking through the Alps had already figured out, through whatever combination of observation, tradition, and consequence that constituted medical knowledge in 3300 BC, that this particular fungus was worth carrying. That it did something useful to the human body, that the difference between having it and not having it was significant enough to include it in a kit where every item had to earn its weight. Researchers who analysed Ötzi's gut contents found that he had intestinal parasites, specifically whipworm, Trichuris tricura. But they also found that he was carrying birch polypore, and here is the part that turns a historical curiosity into something considerably more serious. Birch polypore contains active compounds, including agaric acid and polyporenic acids, that have demonstrated antiparasitic activity in laboratory research. The current scientific literature describes birch polypore extracts as showing activity against a range of pathogens, including bacteria, fungi, and parasites. Ötzi may have been medicating himself, deliberately, with a compound that works. He was not a Viking. He predates the Norse world by roughly 4,000 years, but he is part of the same Northern European tradition of fungal medicine that the Norse people inherited, refined, and continued using throughout the Viking Age. Ötzi is the earliest confirmed evidence of a practice that did not begin with him and did not end with him. He is a data point in a very long line. The Norse and Northern peoples knew their fungi. Not all of them. Some fungi kill you, and a culture that survives long enough to develop a medical tradition learns that lesson early and permanently. But specific fungi identified by consistent appearance, growing on known tree species, in predictable conditions, with reliably observed effects on the human body. These became part of the pharmacopoeia that Norse healers carried and used. Birch polypore was one. Amadou, prepared from horsehoof fungus, Fomes fermentaria, was another, and its role in Viking life is even more documented because it served double duty as both fire starter and wound dressing. The tinder fungus. You find it in the archaeological record, not just as a medical item but as a fire-starting tool, the inner flesh dried and prepared to catch a spark. But here is what makes that dual use medically interesting. Fomes fomentarius, when prepared and applied to a wound, acts as a styptic. It arrests bleeding. The same preparation that lit the fire could stop the blood, and modern analysis of Fomes fomentarius has confirmed the mechanism. The fungal tissue contains compounds that promote platelet aggregation, the same biological process that forms a clot. The Norse healer pressing Amadou against a bleeding wound was not applying a folk remedy with no mechanism. They were applying a biochemically active hemostatic agent to a wound site. The fact that they could not name the mechanism, could not describe platelet aggregation, could not cite a journal article. None of that changes the outcome. The wound stopped bleeding faster. Outcomes are what medicine is. Now understand the broader picture that this paints, because it is easy to look at individual examples and file them away as interesting exceptions. The pattern is what matters. Across the Norse world and the wider Northern European tradition it sat within, fungi were being used with a specificity that speaks to knowledge, not coincidence. Different species for different purposes. Birch polypore for internal use and wound care. Amadou for hemostasis and fire. Fly agaric, the red and white mushroom that appears in Viking-adjacent contexts. In ritual, and possibly in the berserker tradition, though the evidence there is more debated, and we should say so clearly rather than dress speculation as fact. The point is not that every fungal application was correct. The point is that the selection was deliberate. Someone in the Norse world was making choices between fungi based on observed effects. That requires a taxonomy, a working classification system, even if it existed only in transmitted oral knowledge rather than written text. It requires memory and teaching. It requires the kind of systematic observation that produces reliable results reliably enough to be worth teaching in the first place. This is not magic. This is not superstition. This is natural pharmacology, conducted without a laboratory, validated by the only trial that ultimately counts, whether the patient lived or died. But come back to birch polypore for a moment, because modern science deserves more attention than it usually gets. Our current research into Piptoporus betulinus has identified several categories of bioactive compounds. Polyporenic acids have shown antibacterial activity against Staphylococcus aureus, the bacterium responsible for a range of infections, including the hospital-acquired variety that is now resistant to multiple antibiotics and kills tens of thousands of people every year in the developed world. Agaric acid has demonstrated activity against Mycobacterium tuberculosis in laboratory studies. Beta-glucans present in the fungus modulate immune response in ways that are still being mapped. These are not fringe findings in alternative medicine journals. These are peer-reviewed studies in mainstream pharmacology and mycology literature, investigating compounds found in a fungus that a man was carrying on his body before Stonehenge was built. and that timeline is worth repeating. Stonehenge began construction around 3000 BC. Ötzi died around 3300 BC. The scientists studying his medical kit are publishing their findings in the 21st century. The gap between the first use and the scientific confirmation of why it works is over 5,000 years. And in that 5,000 years, the people of the North kept using it. Not because they were told to by a study, because it worked. Because generation after generation of healers applied it, observed the results, noted what improved and what did not, adjusted their practice, and passed the knowledge forward. The clinical trial ran for 5 millennia. The sample size, while never formally counted, is enormous. The conclusion, reached independently by people separated by centuries and geography, was consistent. This stuff works. What modern pharmacology adds is the explanation. The why, the mechanism, the ability to isolate specific compounds, test them against specific pathogens, and describe in molecular detail what is happening when birch polypore extract encounters a bacterial cell wall. That explanation is genuinely valuable. Understanding mechanisms allows you to refine, improve, and deploy treatments with greater precision. Modern science is not irrelevant to this story. But modern science did not discover the medicine. It discovered the reason the medicine works. The Norse healer carrying birch polypore into battle was already ahead of that curve by 1,000 years. Not by accident. Not by divine guidance. By doing something that the modern world sometimes undervalues in its rush toward technological sophistication. Paying attention. Watching what happened when you used something. Watching what happened when you did not. Remembering the difference. Teaching it to the next person who would need to know. There is a comfortable assumption in the modern world that progress moves in one direction. That later always means better. That older always means more primitive. That the tools of the past are interesting only as precursors to the tools of the present. Ötzi's medical kit is a clean refutation of that assumption. Not because ancient medicine was equal to modern medicine. It was not, and we should not pretend otherwise. But because the active compounds in what he was carrying are being studied right now in research facilities as potential treatments for infections that modern medicine is struggling to manage. And the man in the glacier was 5,000 years ahead of the problem. And in the Norse world that came after him, that tradition continued. The fungi were still being gathered. The preparations were still being made. The healers were still carrying them, using them, teaching their use. When the longships launched and the warriors went to sea, somewhere in the kit, alongside the weapons and the rope and the navigation tools, there were things that grew on birch trees, dried and prepared and ready. Not as a curiosity, as medicine, as the kind of medicine that keeps people alive when everything around them is trying to ensure the opposite. That commitment to keeping people alive, the seriousness of it, the sophistication of it, extended well beyond fungi. Because growing in the fields and forests of the Norse world was a plant so pharmacologically dense, so multifunctional, so empirically confirmed by modern science, that it carries the name of a hero who supposedly used it on the battlefield of Troy. The Vikings knew it well. They were right to. There is a plant that grows at the edges of paths, in meadows, along roadsides, in the kind of unremarkable places that most people walk through without looking down. It has flat-topped clusters of small white flowers and feathery leaves that smell faintly medicinal when you crush them between your fingers. It is so common, so ordinary, so present in the northern European landscape, that it barely registers as anything worth stopping for. Its name in Latin is Achillea millefolium. The first part of that name tells you something important. Achillea, named after Achilles, the Greek hero of the Trojan War. Because the legend holds that he used this plant to treat the wounds of his soldiers on the battlefield. That is a myth. But myths do not attach themselves to plants arbitrarily. They attach themselves to plants that have done something impressive enough, over a long enough period of time, that the culture needed a heroic explanation for why everyone already knew to reach for it when someone was bleeding. The Vikings reached for it. Not occasionally, not experimentally, routinely, systematically, as a standard component of wound care that their healers carried, and applied with the confidence of a tool that had earned its place in the kit through generations of reliable performance. While Yarrow appears in the Norse medical tradition with the kind of frequency that indicates not discovery, but inheritance. A practice so well established by the time the Viking Age began that it required no justification, only application. And here is what makes Yarrow extraordinary in a way that goes well beyond historical interest. Modern pharmacology has tested it properly, in controlled conditions, against specific pathogens, specific physiological mechanisms, specific clinical questions. And the results are not ambiguous. Yarrow is hemostatic. It promotes blood clotting and reduces bleeding time, an action confirmed in multiple studies examining its effects on platelet, aggregation, and coagulation cascades. It is antimicrobial. Extracts of Achillea millefolium have demonstrated inhibitory activity against a range of bacteria, including Staphylococcus aureus, Escherichia coli, and several others that cause wound infections. It is anti-inflammatory. Compounds including achillin, achillikin, and various flavonoids present in the plant modulate inflammatory pathways in ways that reduce swelling and tissue damage at injury sites. 3 clinically relevant actions. 1 plant, growing in every meadow in Scandinavia. Stop and think about what a Viking healer had in Yarrow. They had, in a single preparation gathered from the landscape around them, a tool that simultaneously stopped bleeding, fought infection, and reduced the inflammatory response that causes secondary tissue damage. In modern wound care, those 3 functions are typically addressed by separate interventions: a hemostatic agent, an antibiotic, and anti-inflammatory. The Norse healer packed 1 plant into the wound and addressed all 3 at once. They did not know about bacteria. They did not have a framework for inflammation at the cellular level. They did not understand coagulation cascades. What they had was the observed result. Wounds packed with Yarrow bled less, infected less often, and healed with less swelling than wounds left untreated or treated with preparations that did not work as well. That observation, repeated across enough cases, over enough generations, is pharmacological knowledge. It does not require the vocabulary of modern science to be real, but here is what elevates Yarrow from an impressive example to a central argument about the nature of Viking medicine. Yarrow is not alone. The Norse botanical pharmacopoeia was not built around a single remarkable plant. It was a system, a collection of preparations, each selected for specific observed effects, each used in contexts that matched its known properties, each part of a broader framework of herbal knowledge that covered wound care, internal medicine, fever management, pain relief, and conditions that modern medicine would classify across multiple specialties. The healers of the Viking world were not discovering individual herbs by accident. They were working within a tradition that had been mapping the pharmacological landscape of the northern European environment for centuries. Our bog myrtle is the next plant in that tradition worth examining closely, because its story is both ancient and urgent. Myrica gale, the sweet gale that grows in the wet, acidic bogs of Scandinavia and the British Isles, was used throughout the Norse world for preserving food, flavouring ale, and, critically, for its effects on the body when consumed or applied. It contains compounds including myricetin, a flavonoid with documented anti-inflammatory, antimicrobial, and antioxidant properties. It was used in Norse and broader Northern European tradition for digestive complaints, fever, and as a general health tonic consumed through the ale it flavoured. Modern research has examined myricetin extensively and found it active against a range of bacterial and fungal pathogens, each with additional research exploring its potential in metabolic and inflammatory conditions. The Norse people were consuming it daily in their ale, not in therapeutic doses as a deliberate medicine, but in quantities consistent enough that its bioactive compounds were a regular presence in the body. That is not accidental medicine. That is what happens when a culture integrates pharmacologically active plants so thoroughly into daily food and drink that the distinction between diet and treatment effectively disappears. We will return to that idea in a later chapter because it is one of the most important things Viking medicine understood. But first, wormwood. Artemisia absinthium, wormwood, has a complicated modern reputation largely because of its association with absinthe and the 19th century panic about thujone, a compound present in the plant that in very high doses has toxic effects. That association has obscured something important. Wormwood is a serious medicinal plant with a documented history of use spanning thousands of years across multiple cultures, including the Norse tradition, and with a specific application that modern science has validated in a way that is difficult to dismiss. It kills parasites. Artemisinin, a compound derived from a related plant, Artemisia annua, sweet wormwood, is the basis of the most effective modern treatment for malaria. The 2015 Nobel Prize in Physiology or Medicine was awarded in part to Tu Youyou for her work isolating and developing artemisinin as an anti-malarial drug. The plant that won a Nobel Prize belongs to the same genus as the wormwood that Norse healers were using for intestinal complaints, and fever and parasitic infections 1,000 years ago. That is not a coincidence. That is a family of plants with anti-parasitic properties so consistent across species that when modern pharmacologists went looking for malaria treatments in traditional plant medicine, found it in an artemisia. The Norse use of wormwood for intestinal worms and digestive disorders was not folklore. It was the correct application of a plant with genuine anti-parasitic and digestive properties, used by people who had observed exactly the right thing, that it worked. Without having any mechanism to explain why, the mechanism is now known. The thujone and absinthin compounds in wormwood stimulate bile production, improve digestive motility, and have demonstrated antimicrobial and antiparasitic activity in laboratory research. The healer who gave a child wormwood for worms was right. They were right for reasons they could not articulate in the language of modern pharmacology. But the rightness of the treatment does not depend on the sophistication of the explanation. It depends on the outcome. Then there is juniper, Juniperus communis, common juniper, whose berries appear throughout the Norse record in food, drink and medicine, and whose applications map closely onto what modern phytochemistry has confirmed about its bioactive compounds. Juniper berries contain alpha-pinene, limonene, and various flavonoids with documented antimicrobial, anti-inflammatory, and diuretic properties. Norse healers used juniper preparations for urinary tract complaints, kidney and bladder conditions that, without antimicrobial intervention, can progress from uncomfortable to dangerous very quickly. A urinary tract infection in the 9th century, without any treatment, is a path toward kidney infection, sepsis, and death. A urinary tract infection in the 9th century treated with juniper berry preparations, which contain compounds with genuine antimicrobial activity against several of the bacteria that cause UTIs, including E. coli, is a significantly different situation. Not a guarantee of cure, not equivalent to a course of modern antibiotics, but a real, active, pharmacologically grounded intervention that reduced the severity and duration of infections in people who had nothing else available. The Norse healer treating a urinary complaint with juniper was not guessing. They were applying a treatment with an observed track record and using a preparation with genuine biological activity against the organisms causing the problem. The gap between what they were doing and what a modern doctor does is a gap in the mechanism of knowledge, not in the fundamental soundness of the intervention. Now step back and look at what this collection of plants represents together. Yarrow for wound care, hemostatic, antimicrobial, anti-inflammatory, all confirmed. Bog myrtle for systemic antimicrobial and anti-inflammatory support, consumed daily. Wormwood for parasitic infection and digestive disease, from the same genus as a Nobel Prize winning, anti-malarial. Juniper for urinary tract infection, with documented antimicrobial activity against the relevant pathogens. This is not a collection of folk remedies that occasionally stumbled into biological activity. This is a targeted pharmacopoeia, each element selected for observed effects in specific clinical context. Each element validated by modern analysis. And these are not the only plants. They are illustrative examples from a much larger tradition that also included elderberry for immune support, now commercially sold as an evidence-backed supplement. Willow bark for pain and fever, which contains salicin, the precursor compound to aspirin, and valerian for sleep and nervous system complaints, which is actively studied in modern pharmacology for anxiolytic effects. The Norse healers were not guessing at any of these. They were operating within a tradition of plant knowledge that had been refined through consistent observation, filtered by outcomes, and transmitted through a culture that took healing seriously enough to train dedicated practitioners, equip them with specific tools, and bury those tools with them when they died, which is, as it turns out, exactly how we know what we know about who those practitioners were, because the graves tell a story that is even more surprising than the plants. The people buried with these tools were not, as the popular imagination tends to assume, old men with long beards and runic staffs. They were, in many documented cases, women, trained women, women with surgical equipment and medical kits who held positions of genuine social authority in the Norse world. That story is next. And it changes everything about how you picture Viking medicine. There is a grave in Birch, Sweden, that archaeologists have been studying since the 19th century. So Birch was one of the most important trading centres in the Viking world. A place where goods, ideas, and people moved through from across the known world, from Baghdad to Britain, from the Byzantine Empire to the Baltic coast. The people buried at Birch were not anonymous peasants. They were people of consequence, and the contents of their graves reflect that. One of those graves contained a woman. She was buried with scales and weights, the tools of trade and measurement, with a set of keys that indicated household authority, with items that spoke to status, to role, to a position in the community that commanded respect, and with something else, something that, when the full inventory of her burial goods was assembled and examined, told a story about the Norse world that the popular imagination has been slow to absorb. She had a medical kit, not metaphorically, not symbolically. A functional, curated collection of tools and containers that correspond item by item to what a practicing healer would carry. Tweezers precise enough for wound management. Containers that residue analysis suggests held medicinal preparations. Items consistent with the diagnosis, treatment, and care of the sick and injured. She was not a shaman waving smoke over a dying man. She was a practitioner, a trained, equipped, socially recognised medical professional in a world that had decided, for reasons rooted in practical necessity rather than progressive ideology, that healing was serious work and serious work required serious people. Now understand how many graves like hers exist. Across Scandinavia and the wider Norse world, the archaeological excavations have repeatedly produced female burials containing items consistent with medical practice. Tweezers, found so consistently in association with other medical indicators that researchers have begun treating their presence as a potential marker of healer status. Small boxes and containers, often with residue suggesting herbal or medicinal contents. Spatulas and probes. Lancets. In some cases, larger implements are consistent with surgical application. These are not decorative items. They are not jewellery mistaken for tools. The precision of tweezers found in Viking Age graves matches the functional requirements of wound care, removing debris, suturing tissue, managing injuries at a level of detail that requires both the tool and the skill to use it. They were made to do a job, as they were buried with people who did that job. The Norse word that appears most often in the context of these healers is lekna, a term that translates roughly as physician or healer, but carries connotations of trained competence rather than spiritual authority. The lekna was not primarily a ritual figure. They were a medical practitioner in the most functional sense. Someone who examined patients, administered treatments, managed wounds, and applied a body of knowledge that had been learned, practiced, and refined through experience. And the sagas, which are not medical textbooks, but which reflect the social realities of the world that produced them, describe lekna with a specificity that confirms their practical role. They are called to battle wounds. They make assessments. They give recommendations that are taken seriously by warriors and leaders. They are consulted, not merely summoned for ritual comfort. The saga literature treats them the way any society treats its competent professionals, with respect, with expectation, and with accountability when outcomes fall short. But there is another figure in the Norse healing tradition who is harder to categorise cleanly, and who has been both over-mystified and under-examined in popular literature: the vulva. The vulva is typically described as a seeress, a woman of spiritual power who practiced cedar, a form of Norse magic associated with prophecy and the manipulation of fate. And she was that. But the vulva occupied a position in Norse society that blurred the line between spiritual authority and practical knowledge in a way that modern categories struggle to accommodate. Because in a world where the physical and the metaphysical were not cleanly separated, where illness was understood as both a physical and a spiritual disruption. The person with authority over healing was often the same person with authority over the unseen. This is not as irrational as it sounds from a modern vantage point. Modern medicine is beginning to understand, with increasing rigour, that belief, expectation, social support and meaning are not peripheral to healing. They are active components of it. The placebo effect is not a trick. It is the nervous system responding to the signal that help is available. The presence of a trusted, an authoritative figure at a sickbed changes physiological outcomes in ways that are measurable, reproducible, and genuinely significant. Cortisol levels change. Immune function shifts. Pain perception alters. The vulva, walking into a longhouse to attend a sick member of the community, was not only bringing herbal knowledge and diagnostic skill, she was bringing the full weight of social authority, spiritual meaning, and communal trust. And every one of those things has a measurable effect on the body's capacity to heal. The Norse healers were combining pharmacology with what modern medicine is slowly recognizing as psychoneuroimmunology, not because they had read the research, but because they had observed that it worked. The patient who believed the healer could help them healed faster. So the healer who carried both practical tools and social authority produced better outcomes than one with only the tools. This is not mysticism. This is the documented interaction between the nervous system, the immune system, and the social environment. And the Norse world had built it into the structure of their healing practice without ever needing to name it. Now consider the training, because one of the questions that arises when you look at the complexity of Norse medical knowledge, the wound assessment drink, the fungal preparations, the botanical pharmacopoeia, the surgical interventions we will examine in the next chapter, is where did it come from, and how was it transmitted? Medicine of this sophistication does not emerge spontaneously. It requires tradition. It requires teaching, learning, practice under supervision, and the kind of accumulated error correction that only happens when knowledge is passed deliberately from one generation to the next. The Norse world did not have medical schools in the formal sense. What it had was apprenticeship, the transmission of knowledge through direct practice, under the supervision of experienced practitioners in real clinical situations. A healer's assistant who spent years watching diagnoses made, treatments applied, outcomes observed, errors acknowledged and corrected, was accumulating the kind of experiential knowledge that formal education systems try to replicate and often struggle to match. The tools buried with female healers were not inherited ceremonially. They were tools of practice, worn, used, functional. The presence of residue in containers is not symbolic. It is the chemical remnant of preparations that were made and used in the course of actual medical work. These women were not being buried with emblems of a role they held in theory. They were being buried with the instruments of a practice they had carried out in life. That matters because it tells us something about the Norse world's relationship to female expertise that cuts against the assumption that expertise has historically defaulted to men. In the context of medicine, the Norse world appears to have recognised and institutionalised female authority with a directness that many later European societies abandoned. The church-dominated medical tradition that emerged across medieval Europe was deeply ambivalent about female healers. The history of accusations of witchcraft levelled at women with plant knowledge is long, ugly, and consequential. It cost lives, it suppressed knowledge, it broke transmission chains that had been running for centuries, and replaced them with a clerical medicine that was in several documented respects less effective than what it displaced. The Norse world before that displacement had no such ambivalence. The lekna was the lekna. The vulva was the vulva. The tools were in the grave because the work was real, and the person who did it was honoured for it. And the work was serious enough, and the knowledge specific enough, that the tools it required were being manufactured to a standard of precision that implies not just use, but expertise. You do not make a fine-tipped pair of tweezers for a person who will use them clumsily. You make them for a person who has developed the manual skill and clinical judgment to use them well. Someone taught those women, and those women taught others. The transmission of that knowledge in healer to apprentice, generation to generation, refined through practice and outcome, is what gave Viking medicine its depth. It is what separates a culture with medical knowledge from a culture with medical anecdotes. Anecdotes do not get buried with precision instruments. They do not produce wound drinks with triage logic, or botanical pharmacopoeias that match modern pharmacological analysis, or the surgical outcomes we are about to examine. Because there is one more category of evidence that sits above all the rest in terms of sheer confrontational clarity. You can debate the interpretation of residue in a container. You can argue about the precise function of a set of tweezers. You can question how a particular plant was used and whether the use was deliberate. You cannot debate a healed bone. When a skull shows evidence of a surgical hole, and the edges of that hole show bone regrowth, there is exactly one explanation. The patient survived the procedure, and survival in surgery does not happen by accident. The people who carried those tweezers into their graves, the trained, equipped, socially authorised healers of the Norse world, were doing something in the operating space that the bones themselves have recorded. The record is unambiguous, and it is waiting in the next chapter. Bone does not lie, it does not exaggerate, it does not misremember, and it has no interest in making the past look more impressive than it was. Bone simply records what happened to it, but in the language of growth and repair and adaptation, and then waits in the ground for someone to come along and read it correctly. What the bones of Viking Age Scandinavia have been recording patiently for the better part of 1,000 years is this. Surgery happened here. Real surgery. Surgery with instruments, with intention, with a sufficient understanding of the human body and the management of post-operative wounds that the patients, not all of them, but enough of them, a statistically significant enough number of them, woke up afterward and kept living. The most confrontational evidence is the skulls. Trepanation is the practice of drilling, cutting, or scraping a hole through the skull to access the tissue beneath. It is one of the oldest surgical procedures in the archaeological record, found across cultures and continents, stretching back thousands of years, and it appears in Viking Age skeletal remains, with a specific characteristic that separates it from simply finding a hole in a skull. The edges are healed. When bone is cut and the patient dies shortly after, the cut edges remain sharp, raw, unmodified. When bone is cut and the patient survives, when days and weeks and months pass after the procedure, the edges of the hole show the rounded, smoothed, thickened margins of bone that have been through the remodelling process. New tissue growing where the instrument was, the body closes in around the disruption. Life continues on the other side of the operation. The Norse skulls with healed trepanation sites are not evidence of an attempt at surgery, they are evidence of successful surgery. When the patient was on the table, or whatever surface served as a table, a surgeon opened their skull, the procedure concluded, and the patient went home and lived long enough for their bone to tell us so. Think about what that requires. To open a skull and have the patient survive, you need to manage several problems simultaneously and get all of them right. You need to control bleeding at the site, because the scalp is heavily vascularized and bleeds aggressively when cut. You need to avoid introducing infection into an open wound in the bone and underlying tissue, because a surgical site infection in the skull, in a world without antibiotics, progresses toward the brain and kills the patient with an efficiency that leaves no room for error. You need to manage pain sufficiently that the patient does not move in ways that compromise the procedure. You need to close and protect the wound afterward in a way that continues to exclude infection while healing progresses. And you need to do all of this with the tools and preparations available in the 9th or 10th century Norse world. The healed bone tells us they did it. The question the healed bone cannot answer by itself is how, and that is where the convergence of the archaeological record, the saga literature, and the botanical and fungal knowledge we have already established becomes not just interesting, but necessary. Because the surgery did not happen in a vacuum. It happened inside a medical system. The hemostatic properties of Yarrow, confirmed by modern pharmacology, were not irrelevant to scalp surgery. A preparation that promotes clotting and reduces bleeding at a wound site is exactly what you need when you are cutting through heavily vascularized tissue to reach bone. The antimicrobial properties of the same plant and of the fungal preparations carried by Norse healers were not irrelevant to post-surgical wound care. A dressing with genuine antibacterial activity applied to a surgical site in a world without sterile operating conditions is the difference between a patient who develops a fatal wound infection and one who does not. The Norse medical tradition did not have germ theory, but it had, through empirical observation, assembled a collection of tools whose combined effect was to address the most lethal post-surgical complications, bleeding and infection, with preparations that modern analysis confirms are genuinely active against both. That is not luck. That is a medical system doing what medical systems are designed to do, improving survival outcomes through organised, transmitted, consistently applied knowledge. The trepanation cases are the most dramatic evidence, but they are not the only surgical evidence the bones provide. Set fractures tell their own story. Across Viking Age skeletal collections, researchers have identified fractures that show clear evidence of having been reduced, manipulated back into anatomical alignment, and then healed in that correct position. And this is significant because bones that are left unreduced after fracture do not heal in correct anatomical alignment. They heal crooked, shortened, or angulated in the position they were in when callus formation began. A bone that heals straight is a bone that someone straightened, that someone also immobilized it, because a reduced fracture that is not immobilized will shift during healing and produce the same misalignment as an untreated fracture. The Norse world was splinting broken bones, holding them in correct position through the weeks of healing, and doing it well enough that the result is skeletally indistinguishable, at the healed stage, from a fracture managed in a modern emergency department with radiological guidance. They did not have x-rays. They had palpation, the trained hands of a practitioner feeling the fracture site, assessing the displacement, understanding the anatomy well enough to determine what correct alignment should feel like, and manipulate the bone toward it. That skill is not primitive. It is the same fundamental skill that orthopaedic surgeons develop through years of training and practice, deployed without the imaging technology that modern practitioners use to confirm what their hands already know. Then there are the amputations. Healed amputation stumps in Viking Age skeletal remains are perhaps the most quietly remarkable finding in the entire archaeological record of Norse medicine, because they represent a surgical intervention with an exceptionally high mortality risk even in modern settings when performed under field conditions. An amputation requires cutting through skin, muscle, blood vessels, and bone. It requires controlling hemorrhage from vessels that, if not properly managed, will bleed the patient to death in minutes. It requires creating a wound surface that can heal without becoming infected. A challenge even with modern surgical technique, sterile conditions, and antibiotic coverage. The stumps that show evidence of healing are evidence that Norse practitioners were managing all of those challenges with sufficient competence to produce survivors. Not every patient survived. The bones of those who did not are also in the ground, but enough survived that healed stumps exist in the record, which means the technique was not invariably lethal, which means someone had figured out how to do it with a survivable outcome. The hemostatic preparations, in the antimicrobial wound dressings, the cauterization that would have been available through fire and heated metal, the careful wound closure using whatever suturing materials were available, animal gut, plant fibres, hair, the post-operative care that kept the wound clean and covered while healing progressed. None of this appears in a single dramatic description of Viking surgery. It appears in the accumulated physical evidence of people who went through the procedure and came out the other side alive. Dental evidence adds another dimension to this picture. Archaeological examination of Viking Age teeth has revealed filing, deliberate modification of tooth surfaces, with a regularity that speaks to both aesthetic practice and, in some cases, pain management. Dental abscesses, untreated, can progress to systemic infection and death. So the Norse world was managing dental disease in ways that, while not equivalent to modern dentistry, represent an active engagement with oral pathology rather than the passive suffering that the assumption of pre-modern incompetence would predict. There is also the question of pain management during surgical procedures, which is one of the most obvious objections to any account of pre-modern surgery. How do you perform trepanation on a patient who is fully conscious and in pain? The honest answer is that it was not comfortable, and we should not pretend otherwise. But the Norse pharmacopoeia was not without analgesic resources. Preparations containing plants with documented sedative and analgesic properties, including henbane, which contains hyoscine and hyoscyamine, compounds with genuine anaesthetic effects. and which appears in the Norse and wider Northern European medicinal tradition, were available to practitioners who understood their application. The use of henbane as a surgical adjunct is not unique to the Norse world. It appears across ancient medical traditions precisely because it works. The compounds it contains produce sedation, reduce pain perception, and induce a state in which procedures that would be intolerable to a fully alert patient become survivable. The Norse healer performing trepanation was not doing so on a screaming patient held down by force, or at least not always. They had access to preparations that reduced that necessity. This is the picture that emerges when you look at Viking surgery honestly and completely, a practice that was not equivalent to modern surgery in its tools, its understanding of mechanism, or its range of possible interventions, but that was operating within a coherent system of wound management, hemostasis, infection control, fracture reduction, and pain management that produced outcomes, confirmed in healed bone, that should not be possible if Viking medicine was the ignorant guesswork that the popular narrative implies. The surgery was real, the patient survived, the system worked. And what sustained the system? What gave the Norse world the diagnostic sophistication for triage, the pharmacological depth for wound care, the surgical competence for procedures that left healed bone, was not only the knowledge of the healers, it was the daily life of the people being healed. What they ate, what they fermented, what they foraged and consumed without ever calling it medicine. Because the Vikings had figured out something that modern nutritional science is spending enormous resources rediscovering, that the gut is the first pharmacy and the strongest one. What was in a Viking's daily diet was not just food, it was a medical intervention that ran every single day of their lives. There is a concept in modern medicine called functional food. It refers to food that has a demonstrable physiological benefit beyond basic nutrition. Food that does something specific and measurable to the body's systems when consumed regularly. It is a relatively new category, coined in Japan in the 1980s, and it represents one of the faster growing areas of nutritional science as researchers increasingly map the connections between what we eat and how every system in the body performs. The Vikings did not have a word for functional food, they had something better. They had a diet that was almost entirely composed of it, not by design, not because a Norse nutritionist sat down and calculated the optimal intake of bioactive compounds for immune resilience and gut health, but because geography, climate, necessity, and 1,000 years of living in an environment that demanded physical competence from its people had produced a food culture in which almost everything consumed on a regular basis had pharmacological activity beyond its caloric value. They were not eating medicine, they were eating food. It just happened that in the Norse world, the line between those two things had never been drawn. Start with fermentation. Because fermentation is where the story of Viking dietary medicine begins and where modern science is most dramatically playing catch-up. The Norse world fermented everything it could, not as a health practice. As for survival, in a climate where fresh food was unavailable for months at a time, where preservation was not optional but existential, fermentation was the technology that stood between a community and starvation through a Scandinavian winter. Fish was fermented, the Hakal tradition of fermented shark, the various preserved fish preparations that appear throughout the Norse archaeological and historical record. Dairy was fermented, skyr, the thick, strained, cultured dairy product that is native to Iceland and has been produced continuously since the Viking Age, is one of the most directly surviving connections to Norse food culture that exists. Skyr is not yogurt, though modern marketing often positions it near yogurt on the shelf. It is a cultured dairy product with a distinct bacterial profile that produces a food substantially higher in protein and lower in fat than most dairy products. With a live bacterial culture that survives the journey through the upper digestive tract and reaches the colon in a form that has measurable effects on the gut microbiome. Modern research on skyr specifically, not just fermented dairy in general, but the specific bacterial strains present in traditional Icelandic skyr, has found effects on gut bacterial diversity that are consistent with improved immune function and reduced inflammatory markers. The Vikings were eating it every day. The modern world has recently arrived at the understanding that the gut microbiome, the community of trillions of microorganisms living in the human digestive tract, is not a passive passenger in human health. It is an active participant in immune function, inflammatory regulation, neurological signaling, metabolic processing, and disease resistance. The research on this is not fringe. It is appearing in the most prestigious medical journals in the world, and it is consistently pointing toward the same conclusion. The health of the gut microbiome is foundational to the health of the whole organism, and the most powerful way to support that microbiome is through regular consumption of fermented foods with live bacterial cultures. The Vikings were doing this every day of their lives. Not as a supplement, not as a health intervention, for breakfast. But fermentation was only the foundation. The daily diet of the Norse world was built on a series of ingredients that, when examined through the lens of modern nutritional pharmacology, read like a functional medicine protocol assembled by someone with access to the current literature. Wild garlic, Allium ursinum, known in British English as ramsons, grew abundantly in the forests and river valleys of the Norse world, and was consumed in quantities that reflect not just availability, but preference. It appears in Norse food culture with the regularity of a staple, gathered in spring, eaten fresh, and incorporated into preparations throughout the season. Modern pharmacological analysis of wild garlic confirms antimicrobial activity against a range of pathogens, including Helicobacter pylori, the bacterium now known to cause the majority of gastric ulcers, as well as documented effects on blood pressure, cholesterol, and cardiovascular function through compounds including allicin and its metabolites. A Norse person eating wild garlic through the spring and summer was receiving a regular dose of a compound with genuine antimicrobial, cardiovascular, and anti-inflammatory activity. Their gut was more resistant to certain pathogens. Their cardiovascular system was being supported by compounds that modern clinical trials have repeatedly confirmed are active in the relevant biological pathways. They were not doing this because they understood cardiovascular disease or H. pylori infection. They were doing it because wild garlic was there, it tasted good, and the body that consumed it regularly felt better than the body that did not. That last observation, the body that consumed it regularly felt better, is the engine that drove the entire Norse dietary pharmacopoeia. There was no theory, there was only one consequence, and consequence, repeated across enough people over enough generations, is knowledge. Then there is seaweed, and this is where the story becomes almost uncomfortably precise in its modern relevance. The Norse world had extensive coastline and a maritime culture that brought people into regular contact with the sea and everything it produced. Seaweed was gathered, dried, and consumed across the coastal Norse communities, not as a delicacy, but as a food source that complemented inland nutrition with something the land could not provide in equivalent quantities. Iodine. Seaweed is one of the most concentrated dietary sources of iodine in the natural world, and iodine is not optional for human health. It is the mineral that the thyroid gland requires to produce the hormones that regulate metabolism, growth, neurological development, and immune function. Iodine deficiency produces thyroid disorders, goitre, hypothyroidism, cognitive impairment, that were historically devastating in inland populations without access to seafood. In communities that consumed seaweed regularly, iodine deficiency was structurally prevented by the diet itself, with no understanding of thyroid function, no concept of mineral deficiency, and no medical intention of any kind. The Norse coastal communities were supplementing iodine daily through their food culture. The modern world adds iodine to table salt to prevent deficiency disorders in populations that no longer eat in ways that provide it naturally. The Vikings did not have iodized salt. They had seaweed on the table and coastlines full of it, and the communities that ate it didn't suffer the thyroid consequences that devastated iodine-deficient populations elsewhere. They also had something that the modern supplement industry has turned into a multi-billion-dollar category: omega-3 fatty acids, in quantities that most modern people do not approach, even with deliberate supplementation. The Norse diet was built on fish, not as an occasional meal, as a dietary cornerstone. Herring, cod, salmon, and other cold-water fatty fish consumed with a frequency that reflects both availability and preference. Cold-water fatty fish are among the most concentrated natural sources of EPA and DHA, the long-chain omega-3 fatty acids whose effects on cardiovascular health, neurological function, inflammatory regulation, and immune response have been established through decades of clinical research. The modern recommendation for omega-3 intake is calculated specifically with reference to the cardiovascular and neurological benefits documented in study populations. The Norse population was meeting and exceeding that intake as a natural consequence of eating the food that surrounded them. Their cardiovascular risk profile, their inflammatory baseline, and their neurological health, all of these were being supported by a dietary pattern that modern cardiologists and neurologists recommend as a deliberate intervention for people whose diets have drifted away from it. The Vikings were not the deliberate intervention, they were the baseline from which the modern world has drifted. Now add the forage plants that supplemented the cultivated and fish diet throughout the Norse world. Nettles gathered in spring, when they are at peak nutritional density, with iron content comparable to red meat and vitamin C levels that prevent the scurvy that devastated other northern populations with less varied diets. Elderberries, with documented antiviral activity that modern research has confirmed through randomized controlled trials examining their effect on influenza duration and severity. Rose hips are containing vitamin C concentrations that make them one of the most potent natural sources available in the northern European environment. Bilberries and other wild berries consumed seasonally in quantities that provided anthocyanins and other polyphenols with documented antioxidant and anti-inflammatory activity. The Norse foraging tradition was not supplementary to the diet in the way that modern foraging tends to be, a seasonal hobby, a nice addition to a meal. It was integral to the nutritional completeness of a diet that had to sustain people through physically demanding lives in a harsh climate. The plants foraged were selected over generations for the ones worth gathering. And the ones worth gathering were, with remarkable consistency, the ones with the highest nutritional density and the most significant bioactive compound profiles. Natural selection applied to food knowledge works the same way it works everywhere else. The communities that gathered the most nutritious and pharmacologically active plants survived better than the communities that did not. Their knowledge was transmitted. The plants worth gathering kept being gathered. The ones that did nothing dropped out of the tradition. What remained was a dietary pharmacopoeia, refined by survival pressure over centuries. There is one more element of the Norse diet that deserves specific attention, because it sits at the intersection of nutrition and medicine in a way that the modern world is only now beginning to take seriously at a clinical level, ní bone broth when. The long-simmered preparation of animal bones that was a staple of Norse cooking contains collagen precursors, glycine, and minerals that modern research increasingly associates with gut lining integrity. A compromised gut lining, increased intestinal permeability, sometimes called leaky gut in the popular literature, is now linked to chronic inflammatory conditions, autoimmune disorders, and a range of systemic health problems. The compounds present in long-simmered bone preparations have demonstrated effects on gut lining repair in clinical research. The Norse world was eating bone broth because it was nourishing and available and wasted nothing from an animal whose entire body had value in a resource-constrained environment. The side effect was that they were regularly consuming compounds that supported gut lining integrity, reduced systemic inflammation, and contributed to the overall resilience of the digestive system, that their fermented foods were simultaneously populating with beneficial bacteria. This is the full picture of the Viking dietary pharmacy. Fermented dairy building microbiome resilience, wild garlic providing antimicrobial and cardiovascular support, seaweed supplying iodine and preventing thyroid disease. Aconite, fatty fish delivering omega-3 load that modern cardiologists recommend as a deliberate intervention. Foraged plants providing vitamin density and polyphenolic compounds with anti-inflammatory and antiviral activity, and bone preparation supporting the gut lining that is now understood to be foundational to systemic immune function. And none of this was called medicine. All of it was. And the most uncomfortable observation available in this chapter, the one that should sit with you after everything else has settled, is this. The chronic disease profile of the modern Western world maps almost precisely onto the departures from this dietary pattern. Iodine deficiency disorders, cardiovascular disease, chronic inflammation, gut microbiome disruption, omega-3 deficiency, vitamin scarcity, in populations eating calorie-rich but nutrient-poor diets. We did not develop these problems because we became more sophisticated. We developed them in part because we became more convenient. And convenience stripped the pharmacological activity out of food in exchange for shelf life, palatability, and industrial scalability. The Vikings were not healthy because they were virtuous, or they were healthy in the specific ways they were healthy because what they ate was pharmacologically active, and they ate it every day without ever thinking of it as anything other than food. Modern people spend significant money trying to approximate that activity through supplements and functional foods while eating a baseline diet that works against every system those supplements are trying to support. The Norse world had no supplements. It had no functional food category. It had no nutritional science. It had a diet that was, by accident of geography and necessity, almost perfectly calibrated to the body's requirements for systemic resilience. And the body it was calibrating was not just a physical one, because the Norse understanding of health did not stop at the skin. It did not limit medicine to wounds and plants and food. It extended into territory that modern medicine is only now, uncomfortably, beginning to take seriously. The territory of the mind, the territory of community, meaning, ritual, and the profound and measurable ways that the structure of a life can either support or destroy the body that lives it. The Vikings had medicine for that too, and it was built into everything. Modern medicine has a problem it does not always like to admit openly. It is very good at the body and considerably less good at the person inside it. It can map the genome, sequence the microbiome, image the living brain at resolutions that would have seemed like science fiction 30 years ago, and deliver targeted molecules to specific cell receptors with extraordinary precision. What it struggles with, what it has been structurally designed to separate out, to bracket, come to refer elsewhere, is the question of what a human life feels like from the inside, and what that feeling does to the body that contains it. This is not a criticism of medicine. It is a description of a historical division of labour that made sense when the body was the most urgent problem, and the mind was someone else's department. But the division has costs, and one of the places those costs show up most clearly is in the growing body of research demonstrating that the separation was always somewhat artificial, that the mind and the body are not two things sharing a container, but one thing that modern medicine split into two for administrative convenience, and has been trying to reconnect ever since. The Vikings never split, and not because they were philosophically sophisticated about the mind-body connection in the way modern integrative medicine tries to be, but because in the Norse world, the idea that a person's psychological state was separate from their physical health would have been incomprehensible. Illness was not purely a physical event. It was a disruption of the whole person, their relationships, their place in the community, their connection to the seasonal rhythms of the world, their relationship with meaning and story, and the forces larger than themselves. And healing, correspondingly, was not purely a physical intervention. It was a restoration of the whole person to wholeness. That framework sounds like spirituality. In the Norse world, it was also medicine, and modern science keeps confirming piece by uncomfortable piece, or that it was not wrong. Start with social connection, because the research here is now so consistent and so substantial that it has moved from interesting finding to public health concern. The work of researchers, including Julianne Holt-Lundstad, whose meta-analyses examining the relationship between social connection and mortality have been cited by the US Surgeon General in the context of a declared loneliness epidemic, establishes with considerable statistical force that social isolation is a mortality risk comparable to smoking 15 cigarettes a day. Not metaphorically comparable, quantitatively comparable, in terms of its effect on all-cause mortality across large population samples. The mechanism is not mysterious. As social isolation elevates cortisol, the stress hormone whose chronic elevation is associated with cardiovascular disease, immune suppression, impaired wound healing, cognitive decline, and a range of inflammatory conditions. Social connection suppresses it. The presence of trusted people in a person's life is not comfort. It is a physiological regulator with measurable effects on the systems that determine whether the body gets sick, how quickly it heals, and how long it survives. The Viking world was structurally incapable of producing the kind of chronic social isolation that modern developed societies generate as a standard byproduct of their organisation. The longhouse, the communal living structure that was the basic residential unit of Norse life, was not a collection of private apartments. It was a shared space where the people of a household lived, ate, worked and slept in proximity that enforced social connection as a physical fact of daily existence. You could not be lonely in a longhouse, in the way a modern person can be lonely in an apartment building surrounded by hundreds of people they have never spoken to. The community structure around the longhouse extended that connection outward. The Norse legal and communal assembly brought communities together at regular intervals for dispute resolution, trade, news, and collective decision-making. It was not only a legal institution, it was a social infrastructure that required people to show up, to be present to each other, to participate in the collective life of the community in ways that created and maintained the relationships that the nervous system requires for its baseline regulation. Modern people do not have this thing. They have social media, which research increasingly suggests produces the opposite physiological effect. The cortisol spike of social comparison and public performance without the cortisol suppression of genuine face-to-face connection. The Norse world had an actual presence, actual proximity, actual shared experience, and the nervous system responds to those things in ways that no digital substitute has yet replicated. Then there is ritual, which is where the story gets more complicated and more interesting simultaneously. Modern secular culture tends to be uncomfortable with ritual. It associates ritual with religion, and religion with irrationality, and irrationality with things that educated people have moved beyond. But this discomfort obscures something that the psychological and neuroscientific literature is making increasingly difficult to ignore. Ritual works, not because supernatural forces respond to it, but because the human nervous system responds to it. Repeated, predictable, structured behaviour performed at regular intervals, with social and symbolic significance, produces measurable effects on anxiety, cortisol, and the sense of control and meaning that underpins psychological resilience. The Norse world was saturated with ritual. Seasonal festivals, Yule at midwinter, Dísablot in late winter to honour the female spirits associated with fertility and protection, a Sigrablot in spring, associated with victory and the coming season, structured the year into a rhythm of gathering, ceremony, feasting, and collective meaning-making. These were not optional cultural garnishes on the serious business of survival. They were load-bearing elements of the psychological infrastructure that allowed people to survive the serious business of survival without being destroyed by it. Winter in Scandinavia, without modern heating, without artificial light sufficient to compensate for months of near darkness, without the food variety and supply security of modern life, was a psychological challenge as much as a physical one. The communities that had built structures for managing that challenge, collective gathering, shared fire, or ritual that gave the darkness a name and a meaning and an endpoint, navigated it better than communities that had not. Their nervous systems were buffered by the knowledge that this darkness was part of a cycle, that the cycle had a shape, that the shape was known, that they had been through it before and would come through it again. That is not spirituality doing the work. That is predictability and meaning doing the work, through the nervous system's fundamental preference for a world that has structure over a world that does not. Uncertainty is physiologically stressful in ways that are now well mapped. The Norse ritual calendar was, among other things, an uncertainty management system. It told people where they were in the year, what was coming next, and what the community would do together when it arrived. Our modern people have largely dismantled this. The secular Western world has flattened the year into a relatively undifferentiated sequence of working weeks, punctuated by individually managed holidays, without the communal rhythm and collective meaning that made ancient seasonal structure pharmacologically active. The result is not liberation from superstition. It is a nervous system without anchors, navigating time without the structural cues that the organism expects and responds to. The Norse seasonal calendar was not primarily a religious document. It was a prescription for a nervous system that needed to know where it was. And then there is the saga, the story. The role of narrative in human psychological health is one of the most robust findings in modern clinical psychology. And it cuts across therapeutic traditions that otherwise have little in common. Cognitive behavioural therapy works largely by changing the story a person tells about their experience. Narrative therapy is built explicitly on the principle that the stories we construct about our lives shape how we experience them and what futures we can imagine. Trauma therapy, in most of its effective forms, works by helping a person integrate a traumatic experience into a narrative that gives it meaning and location, rather than leaving it as a free-floating disruption of identity. The Norse saga tradition was the most elaborate narrative infrastructure in the pre-modern northern world. Sagas were not merely entertainment. They were the community's method of creating, maintaining, and transmitting the stories through which the social world understood itself. They were performed communally, by memory, in shared space, by people who had developed the skill of recitation as a serious cultural competency. They included histories, hero stories, accounts of legal disputes, genealogies that located every living person within a web of relationship and inheritance, and mythological narratives that gave the community a framework for understanding suffering, death, failure, and the proper response to all three. In a world where most people never learned to read, the saga was the technology through which meaning was distributed. And meaning, the sense that one's life and suffering have a location in a larger story, is not a luxury. It is a clinical variable. Viktor Frankl, the Austrian psychiatrist and Holocaust survivor, built an entire therapeutic school around the observation that the presence or absence of meaning was the most powerful predictor of survival under extreme conditions. His work and the substantial body of research that has followed it establishes that the human nervous system operates differently under conditions of meaning than under conditions of meaninglessness. Pain is more tolerable. Stress is more manageable. The immune system functions better. Recovery from illness is faster. The Norse saga tradition was a meaning distribution system running continuously through the social fabric of the community. You did not go to a therapist to find a framework for your suffering. The framework arrived at the feast, recited by the skald, woven into the stories of people who had faced worse and navigated it with honour. Your losses had a shape. Your courage had a context. Your death, when it came, had a place in a narrative that continued after you. That is not a small thing for a nervous system carrying a hard winter. There is also the Norse concept of the community's responsibility for its members, which runs through the legal and social structures of the Viking world, with a consistency that suggests it was not merely cultural preference, but understood necessity. The obligation to provide for the vulnerable, the old, the injured, the widowed, appears in the legal codes, the sagas, and the archaeological record of burial goods that indicate continued community investment in individuals who could no longer contribute economically. A community that takes care of its members is a community whose members can afford to regulate their nervous systems at a lower baseline of threat. Modern loneliness research keeps arriving at the same finding. The most damaging form of social isolation is not the absence of people, but the absence of people who would notice if you disappeared. The Norse community structure made disappearing structurally difficult. You were embedded in relationships, obligations, and social visibility that meant your absence was registered, your distress was apparent, your need for care was someone else's responsibility to meet. The modern world has largely opted out of that structure in the name of privacy and individual freedom. The trade has costs that the loneliness epidemic numbers are beginning to quantify. The Vikings did not have a word for mental health. They had no diagnostic categories for depression, anxiety, or post-traumatic stress. Though the sagas describe what are recognisably all three in language that is different but not unclear. What they had instead was a social architecture: community, ritual, seasonal rhythm, narrative, obligation, that functioned as a continuous, low-dose, broadly distributed mental health intervention running through every aspect of daily life. They were not in therapy. They were living in a structure that made therapy largely unnecessary for the ordinary strains of ordinary life, because the ordinary strains were continuously absorbed and processed by the systems built around them. And here is the observation that lands hardest when you sit with it fully. The modern epidemics of depression, anxiety, and chronic psychological distress are not primarily the result of people becoming more fragile. They are substantially the result of people being removed from the structures that the human nervous system evolved inside of. Community, rhythm, ritual, narrative, meaning, belonging, and being expected to generate resilience in their absence. The Vikings were not psychologically invulnerable. They lived with violence, loss, disease and hardship at a proximity that most modern people will never experience. But they lived with it inside a structure that was built to hold it. The structure was the medicine, and the medicine worked at the molecular level through cortisol and immune function and inflammatory markers and the neurological effects of meaning and belonging in ways that no one in the Norse world could have described and that modern science is only now mapping in full. They did not have the map, they had the territory. And in the territory they had built, healing was not something that happened to you in isolation when things went wrong. It was something the whole community was doing, together, every single day. Which brings us to the final question this history demands. If the Vikings had all of this, the triage logic, the fungal antibiotics, the botanical pharmacopoeia, the surgical competence, the dietary medicine, the psychological infrastructure, and if modern science has gone back and confirmed, compound by compound, mechanism by mechanism, that so much of it was correct, then what happened to it? And more importantly, who is quietly bringing it back? There is a particular kind of silence in the pharmaceutical industry around certain discoveries. Not the silence of concealment, exactly, more the silence of an institution that has arrived at a conclusion it would prefer not to frame in a way that draws attention to how long the answer was already available. Because when a research team publishes findings confirming that a compound extracted from a plant used in traditional Northern European medicine has significant clinical activity against a specific pathogen or condition, the press release tends to lead with the compound, the mechanism, the trial data, the potential applications. It does not tend to lead with the sentence that the full history demands. People were using this 1,000 years ago, and they were right. That sentence, stated plainly, raises questions that the modern pharmaceutical model finds structurally inconvenient. Mere questions about what else is in the traditional pharmacopoeia that has not yet been tested. Questions about whether the billion-dollar process of developing, patenting, and pricing a synthetic derivative of a traditional plant compound represents innovation or translation. Questions about access, about history, about the relationship between institutional science and the empirical knowledge of people who had no institutions, but had, in their place, something equally rigorous, centuries of consequence-filtered observation. The questions are inconvenient, the evidence is not. Begin with the most familiar example because familiarity should not be allowed to blunt the full weight of what it represents. Aspirin is the most widely consumed pharmaceutical drug in human history, or it is estimated that approximately 100 billion aspirin tablets are taken globally every year. It is used for pain, for fever, for inflammation, for the prevention of heart attack and stroke. And in cancer research, it continues to show activity that generates serious scientific interest. It is, by any measure, one of the most consequential medical compounds ever identified. Its active mechanism depends on salicylates, compounds that inhibit the cyclooxygenase enzymes responsible for producing prostaglandins, the signalling molecules that drive pain, fever, and inflammatory response. Willow bark contains salicin. Salicin is metabolized in the body to salicylic acid. Salicylic acid is the direct chemical precursor to acetyl salicylic acid. Aspirin. The Norse world used willow bark preparations for pain and fever. So did the ancient Egyptians. So did the Greeks. So did virtually every traditional medical system in the Northern Hemisphere that had access to willow trees, which is most of them, because willows grow near water, and water is where people live. The Ebers Papyrus, an Egyptian medical document dating to approximately 1550 BC, describes the use of willow for pain management. Hippocrates described it in the 5th century BC. The Norse and wider Northern European tradition used it continuously through the Viking Age and beyond. Biosynthesized acetyl salicylic acid in 1897 and patented it as aspirin in 1899. The gap between the first documented use of willow bark for pain and the patent on its refined derivative is approximately 3,000 years. For 3,000 years, When traditional healers across multiple cultures were using the correct plant for the correct purpose, through the correct biological mechanism. The 19th century did not discover that willow bark relieves pain. It discovered why, and it manufactured a more stable and precisely dosed version of the active compound. Both things are true simultaneously. Modern pharmaceutical chemistry made aspirin better, and traditional medicine knew about it first. The discomfort comes from holding both truths at once rather than choosing one. Willow bark is the most documented example, but it is far from the only one. Valerian, Valeriana officinalis, was used across the Norse and wider northern European medicinal tradition for anxiety, nervous agitation, and sleep disturbance. It appears in the traditional pharmacopoeia as a calming agent, applied to the conditions that the Norse world would have described in its own language as an unsettled heart spirit, a mind that would not quiet, a nervous system that had lost its ability to descend into rest. The Lechner and the Völva, reaching for valerian root preparations, were making an empirical observation. This plant reduces agitation. It helps sleep arrive. The person who takes it is calmer. Modern pharmacological research into valerian has identified several categories of potentially active compounds, including valerianic acid, which appears to modulate GABA receptors, the same receptor system targeted by benzodiazepines, the class of pharmaceutical drugs that includes diazepam and includes the most widely prescribed anti-anxiety medications in the modern world. The mechanism is not identical, the potency is not equivalent, and the clinical evidence for valerian remains more mixed than pharmaceutical advocates would prefer. But the direction of action, toward the same biological target, through related mechanisms, producing clinically observable effects on anxiety and sleep, validates the observational conclusion that Norse healers reached without knowing what a GABA receptor was. They identified the effect. Modern pharmacology identified the mechanism. The effect was real before the mechanism was known, which is precisely how empirical medicine has always worked, from willow bark to penicillin, from foxglove to digoxin, from the poppy to the entire opioid pharmacopoeia. Elderberry deserves its own moment here, because its trajectory from traditional Norse medicine to modern clinical trials is unusually clean and unusually recent, which makes it particularly useful for demonstrating that this is not ancient history. Sambucus nigra, the elder tree, was one of the most pharmacologically respected plants in the Norse and northern European tradition. Every part of it had uses: the bark, the flowers, the berries, the leaves. The berries specifically were used for immune support, for fever management, for what the traditional record describes in the language of its time as strengthening the body against sickness. In modern language, antiviral and immunomodulatory activity. In 2016, a randomized, double-blind, placebo-controlled trial published in Nutrients examined the effect of elderberry supplementation on the duration and severity of colds in air travellers. The finding, elderberry supplementation significantly reduced cold duration and severity compared to placebo. In 2019, a meta-analysis in complementary medicine research examining the evidence base for elderberry against upper respiratory symptoms concluded that elderberry substantially reduced upper respiratory symptoms. The proposed mechanisms include inhibition of viral entry into host cells and modulation of cytokine production, the immune signalling molecules that drive both the antiviral response and, in excess, the inflammatory damage associated with severe respiratory illness. The Norse healer reaching for elderberry when a member of the community was feverish and ill was applying a preparation with genuine antiviral activity, confirmed in randomized controlled trials published in peer-reviewed journals in the 21st century. The preparation worked in the 9th century for the same reasons it works now, because the biology has not changed. And now come to the more complicated case, the one that requires the most careful handling because the evidence is real and serious, but the history of the compound is also a warning. Aconitum, the genus that includes monkshood, wolfsbane, and various species known and used across northern European traditional medicine, contains alkaloids that are genuinely pharmacologically active, genuinely dangerous in incorrect doses, and genuinely interesting to modern pharmaceutical researchers for specific clinical applications. Aconitine and related alkaloids have documented effects on sodium channels, the ion channels in nerve cell membranes that regulate the transmission of pain signals. For this reason, aconite-derived compounds have been investigated as potential local anesthetics and analgesic agents. And topical preparations containing processed aconite are used in traditional Chinese medicine and have been examined in clinical literature for their effects on musculoskeletal pain, with some positive findings. The Norse and Northern European traditional medicine tradition knew aconite. It knew it as a plant of serious power and serious danger. One of the plants in the traditional pharmacopoeia that appears alongside clear acknowledgement that it requires expertise to handle, that wrong doses kill, and that its power is real in both directions. The healers who used it were not being reckless. They were operating with a precise empirical understanding that the therapeutic window, the gap between a dose that helps and a dose that harms, was narrow, and that narrow therapeutic windows require trained hands. The pharmaceutical industry approaches aconite-derived compounds with identical caution for identical reasons. The toxicology is well understood. The potential clinical applications are real. The requirement for precision in dosing is absolute. The Norse medical tradition and the modern pharmaceutical researcher are, in this specific case, looking at exactly the same plant with exactly the same respect for exactly the same reasons. There is also the birch polypore story, which did not end in the last chapter that discussed Ötzi and the historical fungal pharmacopoeia. It is continuing right now in research laboratories examining the antibiotic activity of polypore compounds against drug-resistant bacteria. The context for this matters enormously. In antimicrobial resistance, the process by which bacteria evolved to survive the antibiotics that were designed to kill them, is one of the most serious threats in contemporary global health. The World Health Organization describes it as one of the greatest threats to global health, food security, and development. The pipeline of new antibiotic classes from conventional pharmaceutical research has slowed dramatically over the past several decades, because finding entirely new mechanisms of antibacterial action is extraordinarily difficult. Where some researchers are now looking is at the natural world, at the compounds produced by organisms that have been running their own antibacterial chemistry for millions of years of evolutionary competition. Fungi, which compete with bacteria for resources and have therefore developed their own chemical weapons against them, are a significant area of this research. Penicillin was the first and most famous fungal antibiotic. Researchers examining birch polypore and related species are asking whether there are others. The man in the glacier was carrying potential antibiotics for drug-resistant bacteria. He just did not know that was what he was doing. The list of traditional Norse and Northern European medicinal plants whose active compounds have been identified, mechanisms confirmed, or clinical activity validated in modern research is substantially longer than this chapter can exhaust. Wormwood and its relationship to the Artemisinin Nobel Prize has already been established. Bog myrtle and the pharmacological profile of miracetin. Juniper and its documented activity against urinary pathogens. St. John's wort, Hypericum perforatum, used in the Northern European tradition for wound healing, and what would now be recognised as depressive symptoms, and now the subject of more clinical trials than almost any other herbal medicine, with meta-analyses confirming activity in mild to moderate depression that is comparable to standard antidepressants with a more favourable side effect profile. Each of these represents the same structure. A traditional observation made without modern tools, validated by modern tools, found to be correct. The pattern is not a coincidence. It is the result of a pharmacological tradition that was doing what pharmacology does, identifying active compounds in the natural environment, selecting for efficacy through repeated use, a refining application through observation of outcomes, without the institutional framework that modern science uses to organise and validate the same process. The institutional framework is better at certain things. It is better at isolating specific compounds, understanding mechanisms of action, standardising doses, identifying contraindications, and scaling production. These are not trivial advantages. They are the reason modern medicine can do things that traditional medicine could not, and the reason that a serious discussion of traditional medicine should never become an argument against modern pharmacology. But the institutional framework did not make the discoveries. The people using the plants made the discoveries. The institutional framework confirmed them, explained them, and in many cases patented a refined version of them and sold them back to a public that had forgotten the original. And this raises the final question that sits at the centre of this entire history. If so much of what the Viking medical tradition did has been confirmed by modern science, what does that say about what has not yet been tested? The traditional Norse pharmacopoeia is not exhausted by the examples in this chapter. There are plants and fungi, and preparations in the historical record that have received little or no modern pharmacological attention. There are combinations of compounds, the way a traditional healer would combine multiple plants in a single preparation, whose synergistic effects have barely been examined by research that tends to study single compounds in isolation. And history suggests the appropriate response to those gaps is not dismissal, it is a curiosity. Because the people who built this pharmacopoeia were paying very close attention, and the things they were most consistently right about were not the ones that required the least knowledge, they were the ones that required the most. Which brings this story to its final chapter. Not a conclusion exactly, but a challenge. Because knowing what the Vikings knew, understanding how they lived and what that living did for their bodies and minds, raises a question that is no longer historical. It is personal, and it is waiting. There is a version of this ending that would be easy to write and easy to dismiss. It would tell you to forage yarrow on your lunch break, brew birch bark tea before bed, or join a Viking reenactment society for the community benefits, and consider whether your chronic inflammation might respond to fermented shark. It would dress nostalgia as prescription and call it wisdom. And you would be right to put it down, because that version of this story would be using 1,000 years of genuine medical knowledge as a lifestyle aesthetic, rather than what it actually is. Evidence. Evidence that the human body has not changed since the Norse world, that its requirements have not changed, that the biological systems which Yarrow addresses, and fermented food supports and community, regulates and ritual anchors, are the same systems running in the body you are carrying through your modern life. Evidence that many of the chronic conditions defining modern health, the inflammation, the gut disruption, any of the immune dysregulation, the psychological fragility, the metabolic disorder, are not the inevitable price of civilizational progress, but the predictable consequence of removing the conditions the body was built for and replacing them with conditions it was not. The Vikings did not have better medicine than us in every respect. Let that be absolutely clear before anything else in this final chapter. They did not survive cancers that we cure. They did not manage organ failure that we treat. They did not prevent childhood deaths that modern vaccination has reduced to a fraction of what they once were. The average lifespan figures for Viking Age populations are not something any honest person would choose over the present, and the violence, famine and infectious disease that shorten those lives are not romantic when examined directly, but within the specific domain of what their medicine addressed: wound care, infection management, systemic resilience, psychological health, the daily maintenance of a body under significant physical demand. They were doing things that modern science has confirmed were correct, through mechanisms that modern science has taken centuries to understand, using resources that in many cases are still available to anyone willing to look for them. That is the precise accounting this ending requires. The first thing Viking medicine understood, that the modern world has largely forgotten, is that the environment is the first pharmacy, not the supplement store, not the prescription pad. The environment. The landscape around the body, the quality of the air and light and water the body moves through, the plants growing at the edges of paths, and the fungi on the birch trees, the cold water, the seasonal temperature shifts, the darkness at night and the brightness at midday. These are not background conditions for health. They are active inputs into biological systems that evolved to receive them, and that function differently, measurably, consequentially differently, when they are absent or replaced with inferior substitutes. The Norse healer carrying birch polypore understood this not as a philosophy, but as a practice. The environment contained medicine. Your job was to know where it was, how to prepare it, and when to use it. The modern world has largely outsourced that knowledge to institutions, which is not inherently wrong, but has produced a population that moves through a landscape full of pharmacologically active plants and fungi, with no awareness of what surrounds them. As the knowledge was not lost because it stopped being true, it was lost because it stopped being taught. Some of it can be reclaimed without pretending you live in the 9th century. Yarrow still grows at the edges of paths. Elderberry still fruits in autumn. Wild garlic still carpets the floors of damp woodland in spring. The plants are not historical artifacts. They are present, available, and confirmed by modern pharmacology to be doing what the Norse tradition said they did. You do not need a laboratory to use them. You need the knowledge that was once transmitted as a matter of cultural survival and is now available, somewhat scattered, in the literature of ethnobotany and phytopharmacology for anyone willing to look. The second thing Viking medicine understood is that food and medicine are not separate categories. The modern world has built an enormous institutional boundary between nutrition and pharmacology, between what you eat and what you take to treat illness. This boundary is partly logical, partly regulatory, partly commercial, and partly a consequence of the reductionist tendency to study single compounds in isolation, rather than the complex synergistic, whole diet effects that the Norse world was relying on. But the boundary is increasingly difficult to defend scientifically as nutritional research accumulates evidence that dietary patterns, not individual nutrients but the whole architecture of what a person eats and how they eat it, determine inflammatory baseline, immune competence, gut microbiome health, cardiovascular risk, neurological function, and metabolic resilience with an effect size that rivals pharmaceutical intervention for the prevention of chronic disease. The Viking diet was not a designed therapeutic protocol. It was what people ate because it was available, because it preserved well, because it sustained physical performance in a demanding environment, and because the communities that ate it survived better than communities that did not. The fermented dairy, the fatty fish, the wild garlic, the seaweed, the foraged plants, the bone preparations. These were not medicine adjacent to food. They were food that was medicine, and the distinction the modern world insists on drawing between the two would have made no sense to the person preparing skyer in a Norse longhouse. The practical implication is not complicated, though following it in a modern food environment requires deliberate resistance to convenience. Eat fermented food regularly. Eat fatty fish regularly. Eat wild plants when you have access to them. Eat food with structural complexity. Food that requires your digestive system to work, that releases compounds slowly, that does not spike and crash your metabolism in the way that industrial food engineering has optimized food to do. The Norse dietary pharmacopoeia is not a historical document. It is a nutritional argument that modern research keeps confirming, available to anyone who chooses to eat in its direction. The third thing Viking medicine understood is that the body is a system, and systems require integrated treatment. The Norse healer did not treat a wound, as they treated the person with the wound, managing the immediate injury with hemostatic and antimicrobial preparations, supporting the systemic recovery with food and rest and community care, addressing the psychological dimension of pain and vulnerability with the ritual and narrative infrastructure that surrounded every significant event in Norse life. The wound was an entry point into the whole person, not the entire scope of the clinical problem. Modern medicine's tendency towards specialization, which produces extraordinary depth of knowledge within narrow domains, comes with a systemic cost. The patient experiences their illness as a whole, but is treated in parts. The cardiologist manages the heart. The gastroenterologist manages the gut. The psychiatrist manages the mind. The nutritionist, if consulted at all, arrives separately. The integration that Norse medicine performed instinctively, because it had no institutional structure to fragment it, is something modern integrative medicine is trying to rebuild, deliberately, expensively, and with considerable resistance from the systems that specialization built. The argument is not that specialization was wrong. It produced the depth that allows modern medicine to do genuinely miraculous things within its domains. The argument is that it came at a cost, and the cost is paid most heavily by the patients with conditions that do not sit neatly within a single domain. The chronic inflammatory conditions, the metabolic disorders, the psychological somatic presentations that fall between specialties and are managed rather than resolved because no single specialty owns the whole picture. And the Viking healer owned the whole picture because the whole picture was all there was. It is not a model that modern medicine can simply return to, but the principle that the body is a system and that treating a system requires understanding its integration is one that modern medicine is arriving at through its own evidence and that the Norse tradition embodied from the beginning. The fourth thing Viking medicine understood is that community is not comfort. It is medicine. This may be the hardest reclamation for the modern world, because it requires not a change in what you consume or how you move, but a change in how you live. And how you live is shaped by economic structures, urban design, cultural values, and social norms that no individual can simply opt out of by deciding to care more about connection. But the biological argument for community as medicine is now established beyond reasonable dispute. Chronic social isolation elevates inflammatory markers, suppresses immune function, dysregulates cortisol, accelerates cognitive decline, and increases all-cause mortality with an effect size that the research literature describes as substantial. The presence of trusted social relationships does the opposite. It is not supplementary to health, it is constitutive of it, in the same way that adequate sleep and adequate nutrition are constitutive of it. The Norse world did not produce this outcome by trying. It produced it by building social structures in which isolation was architecturally difficult, community participation was a survival requirement, and the care of vulnerable members was a collective obligation rather than an individual responsibility. Modern people cannot reproduce the longhouse, but modern people can ask, with genuine seriousness rather than the performative seriousness of a wellness trend, whether the structure of their lives is producing the conditions their nervous systems require. Do you have people who would notice if you disappeared? Do you participate in collective life in ways that are regular, embodied and socially visible? Do you have shared ritual with the people around you? Not necessarily religious ritual, but the structured, repeated, meaningful collective behaviour that the research consistently identifies as psychologically protective? These are not questions about lifestyle preferences. They are questions about biological requirements that the Norse world met by default and that the modern world requires conscious reconstruction to meet at all. The fifth thing, Viking medicine understood, and perhaps the most subversive, in the context of a modern medical culture that has industrialised healing into a product delivered to passive consumers, is that healing requires participation. The vulva did not treat a patient who sat waiting to be fixed. The lekna did not deliver medicine to a person with no role in their own recovery. The Norse healing tradition, in its integration of botanical knowledge, surgical skill, dietary support, community care and ritual meaning, assumed that the person being healed was an active participant in the process. The belief of the patient mattered, not as a placebo to be apologised for, but as a genuine component of the healing mechanism. The meaning the patient found in their illness and recovery mattered. The social support surrounding the patient mattered. The food the patient ate during recovery mattered. The rest the patient took mattered. Modern medicine knows all of this. The research on patient participation, on the therapeutic relationship, on the role of meaning and social support in clinical outcomes is substantial, consistent, and largely ignored at the level of healthcare system design. Because healthcare systems are designed around what can be standardised, scaled, and built, and the participatory, relational, meaning-rich dimensions of healing resist all three. The Norse healing tradition could not be scaled. It was bespoke, local, relational, and embedded in a specific community and culture. And that is its limitation as a model for modern healthcare. But it is also its instruction, because the things that could not be scaled are precisely the things the evidence keeps identifying as most therapeutically significant. The relationship with the healer, the meaning attributed to the treatment, the social support during recovery, the dietary and environmental conditions surrounding the illness, the participatory belief that healing is possible and that the patient's own body is capable of it. These things are not available on prescription. They are available through the way a person constructs their life. So here is the challenge this history leaves on the table, stated as plainly as the evidence allows. The Vikings did not have better technology than you. They had worse technology. They had no imaging, no antibiotic synthesis, no surgical anaesthesia, no germ theory, no understanding of molecular pharmacology. In a direct comparison of tools, modern medicine wins without contest, and no honest account of Viking medicine should suggest otherwise. But they had something that modern people are measurably, consequentially losing. A life structured in alignment with what the human body actually requires. Regular physical movement woven into daily existence, rather than scheduled around sedentary hours. Food with pharmacological activity, rather than food engineered for palatability and shelf life. a social architecture that produced community and belonging as a structural default rather than a personal achievement. Darkness at night and light in the morning, seasonal rhythm, collective ritual, narrative that gave suffering a location in a larger story. It's the expectation that the natural world contained medicine and that the healer's job was to know it. None of these things are locked in the past. None of them require a longhouse or a Viking ship or a belief in Norse gods. They are available right now, in the body you have, in the landscape you can access, in the social choices you can make, in the way you decide to eat and move and gather and rest. The birch polypore is still on the birch trees. The yarrow is still at the edges of paths. The wild garlic still flowers in spring. The cold water is still cold. The night is still dark when you let it be. The body still responds to fermented food and fatty fish, and the company of trusted people, and the knowledge that its suffering has a meaning, and its community has not forgotten it. The best medicine the Vikings had was not stored in a healer's kit. It was built into the structure of the world they lived in. And the most important thing this history offers the modern person is not a collection of herbal remedies or an argument against pharmaceutical medicine. It is a different question about the same problem. Not, what can I take to fix this? But, what conditions does my body need to heal itself? Because the Norse healers, the Lekna with their surgical kits, the vulva with their botanical knowledge, the communities with their fermented food and seasonal ritual, and saga-told meaning, understood something that 1,000 years of medical progress has complicated without disproving. The body already knows how to heal. It has always known. What it needs is not to be conquered into health. It needs to be returned to the conditions that make health possible. Most of those conditions are not waiting to be invented. They are waiting to be remembered. You have just travelled through 1,000 years of medicine that the modern world almost forgot to take seriously. You have seen a battlefield triage system that mirrors the logic of modern trauma surgery, built from herbs and observation in the 9th century. You have seen fungi carried on human bodies 5,000 years ago that pharmacology laboratories are studying right now for antibiotic activity against drug-resistant bacteria. You have seen a botanical pharmacopoeia confirmed compound by modern clinical research. You have seen surgical patients who survived procedures in a world without sterile technique or pharmaceutical anaesthesia, and left the evidence of their survival written in healed bone. You have seen healers, trained, equipped, socially authorised women, buried with the instruments of a practice serious enough to bury with them. You have seen a diet that was systemic medicine by accident of geography, and a social architecture that was mental health infrastructure by necessity of survival. And you have seen, in almost every chapter, the same uncomfortable pattern. Modern science arriving at a conclusion that a Norse healer reached 1,000 years earlier through different tools by the same method, paying attention, testing against consequence, keeping what worked. The history of Viking medicine is not a story about the past. It is a story about what the human body has always needed, nay, and what happens when the world it lives in either provides those things or takes them away. The Norse world provided many of them, imperfectly, within a life that was harder than most modern people will ever experience. The modern world has removed many of them, invisibly, within a life more comfortable than any that came before. The challenge, the real one, the biological one, the one this history leaves sitting in your hands, is to look clearly at what was lost and decide, with the evidence now in front of you, what is worth rebuilding. Not as nostalgia, as medicine. If this journey changed the way you think about healing, about history, about the body you are living in right now, then there is more where it came from. Subscribe to Viking Times. Every story we tell is built the same way this one was. From the archaeological record, from the historical sources, from the science, and from the honest conviction that the past is not finished with us yet, that the people who came before us were not waiting to be rescued by the future, that they knew things we have forgotten, survived things we underestimate, and built things we are only now learning to appreciate. The Norse world has more to teach. We are not done yet,